Yeah. So for that, I want to invite a very, very special person. Okay, and this is the person I've had the privilege to work with here. Is that for the past 7 years? Wow, my goodness, I can't believe time flies that. And this is, I said, Beth Ann Patterson. She is, I said, the director of the sleep program in Sauk Prairie Health. And let's make sure, Beth Ann, you have the microphone too. But, okay.
Amazing sleep tech, Dawn, always taking care of me.
Okay, so everyone, please a round of applause for Beth Ann. Please come in here to the podium. Yes. Okay, thank you very much. And again, just in a very similar vein, we'll do something that's similar to this. So this will also give a little bit more of a background, but then some asked questions. So instead of me trying to come with the answers, let's ask to someone who's done what I'm saying here, right? Not just. So again, the goals here is to make sure that at the end of this talk, you will understand is that the unique challenges and opportunities of establishing a sleep center of excellence in a rural setting, okay? And all the different considerations that come with it. Also to gain some insight into the essential components of one of these programs. In other words, I'm trying to give here the secret sauce, okay? And also to apply the practical knowledge and skills to overcome the barriers that are very unique and specific to rural patients. Now, for some of those who might be working, as I said, in Milwaukee or Chicago and Madison, well, I'll tell you, most of Wisconsin is rural, so I have to make sure that we all have a voice here. So again, let's start here with the American Academy of Sleep Medicine. They started as the Association for Sleep Disorders in 1975, and it is the only professional society fully and exclusively dedicated to the practice of sleep medicine. And they set the standards and promote sleep medicine research and education. And there's over 11,000 accredited member sleep centers and individual people. There are 4 different types of accreditations, okay? So the first is for a sleep facility, what in the past used to be called a comprehensive sleep center, okay? Then we have independent sleep practices, which in the past was the home sleep apnea testing only facilities, DME suppliers, and specialty practice. This is a new one. So comprehensive sleep centers, 1, it has to have a clinic. And 2, there has to be a lab where you can do home tests and in-facility or in-lab sleep studies. The independent sleep practice has a sleep clinic, but they only do home sleep apnea tests. And well, I won't talk about DME, but about the specialty practice, which is sort of unique and especially targeted to cardiology, is that this is for non-sleep medical practices. So if any of you have a large cardiology group attached to you, this is something they can use. It allows them to screen people with sleep apnea, and you can talk about their own guidelines. So if you go to the guidelines of the American College of Cardiology, American Heart Association, they talk about the importance of screening for sleep disordered breathing in people with cardiac arrhythmias or heart failure. So you can even quote and use their same guidelines to them about the importance of screening for sleep disorders. And the prevalence of sleep disordered breathing is extremely high. But with them, it just allows them to screen these patients, sort of dispense home sleep apnea testing, and then partner with a accredited sleep center. Now, as I was saying here, is that the most of Wisconsin is rural. See those little blue spots? That's where the cities are. Everything else, everything green, it's rural, yes. Okay? So we are country bumpkins. Now, see all those little spots? Those are pretty much, I said, rural, I said, healthcare facilities, okay? So these are small labs. Some of them might be critical access, those in blue. The ones in green are non-critical access rural hospitals. And then the little red dots are federal, So again, we have plenty of small rural centers, and a lot of people depend on these places. Now, there's a lot of barriers, okay, that are unique to rural health. First is the distance of transportation, workforce shortages, health insurance coverage, broadband access, poor health literacy, and social stigma. A lot of people, if they go and seek health, they know their neighbors will say, oh, but so you're the guy who uses one of those machines, or the one who's the depressed person. And they don't want them to be known as the sick person, okay? So there can be a lot of things. So here again, you can see that in red are all the places where it takes more than a half an hour to drive towards healthcare, okay? So large parts of the state are beyond, and those in white, it doesn't even apply because it's even more, okay? So, and they're in yellow are those where it takes 20 to 30 minutes to arrive. So most people have to drive long distances to get healthcare. And these areas in the orange are the areas where you have a shortage of workforce, where there's not enough docs, physicians, nurses, RTs, sleep techs, okay? Now, if you have a small rural community, is it easy to hire? How many people say, nah, it's just too small, schools aren't too good, what will I do for fun? Okay, so it's really, really tough. Okay, so unless you have a connection there with family or friends, it can be very tough to get into those small places. Health insurance coverage. Okay, what I want to highlight here is that compared to cities and all that, I said here in light green, you see both for children and for adults, you'll see that the amount of uninsured or those who are on medical assistance is much higher amongst those individuals who live in rural populations. Okay, so there's less payment if you're in a small rural place. Not only that, but this is if you want to see something cool, you can go to, there's maps of the US under the SCC, so not just the guys who tell you that whatever comes on TV is bad, but you can also see about the broadband access in the US. And you can also take Microsoft, they have a project where you can also see that, but you can also overlap that. And there's a lot of places where it's the light blue, where there are, I said, poor internet access. And you can also, there's another study that's very cool that overlapped poor internet access, broadband connection to healthcare outcomes. So it is just like a social determinant of health. If you don't have connection to fast internet, your health will do worse because it's tougher to access people. And there's, I said, serious challenges, right? I mean, places have been closing. Look, all these green bars are places that are closed. And just earlier this year, right, I mean, we had, I said, a couple of facilities that closed in Eau Claire, the effect here in our state. So, yeah, not fun at all. So we must do things to improve, I said, the access of healthcare in rural places. So we have to think about how can we deliver care in a way that's more thoughtful and unique, that takes care of the people who are there, but also that doesn't bankrupt, the small rural communities and facilities that take care of all these patients. Partnerships, so they can be done in various ways, either as part of a larger healthcare system or just, as I said, affiliations, or even contracting some third-party facilities that might have like a turnkey operation. There can be also efforts to improve, I said, the workforce, training people, just like we talked with Marla, telehealth, okay, so smart commuting, right? So let's seek for expert advice. So what better expert than Beth Ann, all right? Okay. So about Beth Ann, again, as I mentioned, Sauk Prairie Healthcare, she's the Director of Better Health and Respiratory Services, Director of the Sleep Center. And again, I'll tell you this because last year, I said there was an accreditation at the honor to be there, witness, and I have some other people who were there in that accreditation. And for those who've been accredited, how many of you have been accredited by a PhD sleep specialist? Aren't they a little bit more of a pain than the MDs when they come to see you? Okay, yeah. So, fine to come, okay. And this person said, I've seen hundreds of places, and I must tell you that this is amongst the top 1% centers I've seen in all the time that I've been doing this. Okay, so not exaggerating here, so that's why I put it here as a quote. So, Beth Ann, why don't you tell us here a little bit more about yourself and how you became here the director of the Sleep Center in Sauk Prairie.
Okay. Hello, everybody. I'm Beth Ann. Thank you for the introduction. I am actually a respiratory therapist. Are there any other RTs in here? Woohoo! Look at that. Way to represent. Nice job, guys. So by trade, I'm a respiratory therapist. Before that, I was a CNA. So I started at Sauk Prairie Healthcare back in 1997. I know, I look like I'm 24, but I'm really not. So when I was in 5th grade, no, I'm just kidding. I had to keep you guys awake. You really ate really great food, and you guys are normally sleeping right now, so thank you for being awake and listening to us. So I went on for RT school, went back to Sauk Prairie Healthcare in 2002. In 2010, I was promoted, and I was so excited. I had a RT department and a sleep lab. I think I had a whopping 3 FTEs. That was it. But I was excited, and Sauk Prairie Healthcare is very rural. We have a 36-bed facility, but we are a not-for-profit rural hospital, which there are not many of us, so I'm really proud to say that and to share that, especially when you see facilities closing. You have to start being really creative. And I'm sure I get a question down the road here, but how does Beth Ann Patterson meet Dr. Villarreal? Here, 8 years ago, I came to my first Wisconsin sleep conference. I am an RT, but for some reason, sleep just intrigues I just love it. It started with those of you who've been in the field long enough as RT. You probably were like me, where all of a sudden we only have a night tech. So, hey, RT, while you're taking care of your vents and your patients, go hop in the sleep lab, call those patients, and tell them the results that the doctor told you to tell them on the piece of paper. That's how it started, and that's where I fell in love with sleep. So I'm like, yeah, I want to go to this conference. And I was eating lunch, and this speaker comes over, Dr. Villarreal, and says, can I sit with you? And I'm like, sure. And that conversation went on and on. We were actually late to the afternoon session because we just kept talking. And he has such a love for sleep, and it just intrigued me. And that's how I got to meet Dr. Villarreal. And that's why earlier today, one of my sleep techs, Dawn, shared with me that larger facilities aren't supporting conferences anymore for their sleep techs. And that hit me hard, because if I didn't have the support of my facility to come to this conference, I would have never met Dr. Villarreal, and we never would have grown our sleep program to where it is today. And I think that networking is the biggest piece of going to a conference, is getting to know other sleep techs, other RTs, what works well for them, maybe works well for others. It's good to share what doesn't work so good, so you can learn from other people. So I'm really appreciative that you guys are here, whether you had to pay for yourself or for your organization to pay for you to come here, because it's important. We learn so much from each other.
Thank you so much. I mean, that was really flattering. I think I'm a little blushed right now, but let's go here to the next step, which is important. So when we first met, is that you have pretty much had a sleep lab, like in the old terms, where your program was being supported by a sleep clinic that was run by another organization. I think there was some outreach in the traditional point of view, 2-bed labs, but now you said you started with 3 FTEs. How many FTEs do you have now, and how did you get to the point where now you have a full-fledged functioning sleep clinic and pretty much taking care of all types of sleep problems?
Yeah, so our sleep lab opened, I think it was in 1996. By the time I got to meet Dr. Villarreal, now we're jumping forward to 2015, we have a 2-bed lab. I have 24 FTEs, 6 departments, like 3 physicians, and I finally got approval for 2 supervisors after all that, so I'm excited about that. And I have a sleep coordinator. So for our sleep program, the biggest collaboration was we had a lab with an external entity that ran the clinic. So basically, they sent us and we did the tests. When I got to talk with Dr. Villarreal, I really understood more of the concept of that whole continuity of care piece. You know, we did the test, but then they were somebody else's, I don't want to say problem. We turned their care back over. And we want to do more of a holistic approach, and how can we help that person through their whole journey? Because it's a journey, it's not just a test where you get a result, right? You guys know that better than anybody. So we decided we had to do a lot of detail, which I know we'll talk about in a little bit later of this presentation, but to justify the need for a clinic, we had full support of our administration, but we had to get a lot of data, a lot of pop health information. We know there's a lot of undiagnosed OSA patients that don't get treatment, and in a rural community, maybe to drive from Sauk Prairie to Madison, it maybe is only a 35-minute drive, but there's a big population that can't make that drive, or they're scared. It's Madison, Milwaukee, La Crosse, To some of our farming community members, that right there is a no. They're too scared. So how can we serve them in our own community? So we started exploring different models, and the model we chose, because Dr. Villarreal loves Gunderson so much, I couldn't convince him to come work at Sauk. I still try, can you tell? Is to have a nurse practitioner. So to find a nurse practitioner, we did find a great nurse practitioner, had no experience in sleep, but with Dr. Villarreal's mentorship and his peers, we were able to hire a nurse practitioner and an MA and a sleep coordinator to start our sleep clinic back in 2017.
Yeah, well, excellent. So how would you say that training, is it that nurse practitioner did help, grow the program, having the clinic there pretty much most days of the week compared to just the traditional outreach?
Yeah, what's a trick when you're in a rural community hospital is we don't have a sleep specialist, we don't have a pulmonologist, we don't have a cardiologist. We have a family practice, maybe some other ortho and specialty surgeons. So how do we train a nurse practitioner who doesn't have a physician right there? So in collaboration with La Crosse and Gunderson, we actually sent our nurse practitioner up to work with Dr. V and his NPs and other APPs for 5 weeks, and that's where they got all their hands-on training. And then when they were ready, they came back. We started our practice slow. So we started with 4 or 5 patients a day. And at the end of every day, this gentleman right here would talk one-on-one with my nurse practitioner. Not just for 1 week, not for 2, for 6 months. So 3 to 4 days a week, at the end of every clinic, Dr. V would go through all the patients with my nurse practitioner to make sure that, A, they did the right treatment, but really, I think more importantly, to show them support. Because it's important that that nurse practitioner who is 100 miles away from them still feels the support of that physician. So our nurse practitioners also have his cell phone. They can call him at any time. And I know they very much value that.
Yeah, thank you. But again, in my experience, having a person there is very, very important. In the good old days when we had our mildly overweight middle-aged person who snored could have a test. Now with the advent of home studies, you need to see many more new patients to have just one in-lab study. So that traditional outreach doesn't work, going to one place once a month. It's just not enough. And then I feel the privilege of working, as I said, in a rural setting for many years. I said back in Pennsylvania, back here in Wisconsin here too. And I find that people who live in rural communities are salt of the earth type of people, really great values, people who are very hardworking, people who tend to show up to their appointments even when there's like snow and sleet. And it's like, okay. And then the other thing too is they tend to be very proud of their communities. So if they have a small hospital, even if it doesn't have much, so they want to support it. So most people want to support their own community. So I think it's a way in which we can help the community empower their own facility so that they can survive and provide valuable care to patients again close to home. Otherwise, I mean, I did see people who had to take off a full day of work so they can drive an hour each way for just a short appointment or a follow-up appointment too. So yes, 1 year CPAP, you're doing great like you did in the past 10 years, high five, and here's a prescription for supplies. So this way it's much more valuable, it's more personal. And I feel that by this, as I said, advanced practice clinician being a member and a staff member of the facility, they have the vested interest in making this program succeed because they're part of that program. But we talked about the training a little bit here. And then one of the things is what type of support staff did you hire for the sleep clinic and why did you do that?
Okay, here comes my shout out. Oh, and Shadi leaves. I see how he operates. I have 2 sleep techs here who are phenomenal. Oh, thank you. Here comes Shadi. Everybody give him a round of applause. Him and Stephanie. Stephanie's not here, Dawn, with our sleep techs. One thing that was new to me with a clinic is working with medical assistants, and I have 2 of them here. And this part of this training, and if I can encourage any of you guys to go back who have clinics, is it's just as important for the sleep techs to be here as our medical assistants. So there's my Amy and Abby. And I invited them here because they're our backbone to our clinics and our labs. And they're the ones talking to the patients. They're the ones who are getting that trust of the patient. And it's amazing what these two ladies can get out of a patient. I will tell you that. That's what our providers will say. And empowering them and engaging them into sleep education is going to make your program that much stronger, right? Because the last thing we want to do is have somebody answer the phone and give our patients the wrong advice. And there's not a textbook I can give them to say, here's everything you need to know about sleep, 101. It doesn't happen. It's with experience. So I appreciate that these guys came here so they can talk and they can learn from all of you guys. But I'm huge on training. I encourage training. Sometimes I have to try to push a little bit to get people to go to these in person, because so much is virtual now. And it's easy, right? Especially if you have a busy life. But coming in person and encouraging your support staff to come is just as important as our sleep techs and our APPs. Oh, I have to talk about one more really, really important, don't I? I know, sorry, he's not here. So one of the things I'm super proud of is that in 2022, we started doing analysis of our volumes. We knew in clinic our volumes, our provider was max. She was 100 to 110% filled every day. That wears on your provider and it wears on their support staff. We knew we needed to expand. So pulled a bunch of data to justify, and we've now doubled our staff. So in the fall of 2023, I added another MA, another nurse practitioner, and we started a pilot, which took off and is full-time now. He's 0.8. But we hired a registered respiratory therapist who is our sleep case manager. It has made a huge impact on our program in compliance, right? So if there's one thing Dr. V has taught me, he's taught me a lot, but it's in our clinics, we want to see new patients. Yes, for the revenue, but also to start their journey, right? These follow-up patients fill up our clinic schedules, and that means we have not much availability to get these new patients in. So by having a case manager, whether that's an RT, whether it's a sleep tech, somebody that can help that patient on their journey. I'm not going to go too much into DME and how they take care of our patients, but they're just as stressed with staffing. We know they can't give what our patients need. Let's be honest, right? There's so many of them. Our goal is just to get them to get a machine some days, is to have that patient who's holding them accountable. So they meet James during their visit. They get to know that he is there to help and to support them. If they're having trouble, pick up the phone, call us. He will run a download. He will bring you in. So for the first 30 to 90 days, we don't charge any additional. You come in, you will see him. He will try different masks with you. He'll do whatever he can do to get you compliant. Once you hit that 90 days, then you should be soaring and you should be doing well. And if you have troubles after that, that's when we have an opportunity to bill for his services. So I know that's one thing Dr. V wanted me to share, like what does that look like? So if you have somebody that can work alongside your APPs or your providers, you have to be an established patient. So let's have a patient who is maybe 2 years out, all of a sudden struggling, just can't seem to make it through the night, their compliance is going down. Should I get in to see your doctor or the APP or whoever? Well, the APP can actually refer that patient, because they're established, to the case manager. The case manager can go ahead and bring that patient in, give them that one-on-one personal care, go through masks, go through their machine, work with the DMEs, and we can bill for it as an incident too. So the thing is, you got to make sure that that happens on the same day a provider is in your clinic, and the billing is actually under your provider as an incident too. So it's a way to bring revenue into your program, but it also does not bog down your provider's schedule, so you can see new patients and bring in the more complicated patients for your providers to handle. And when it's compliance issues, your case manager can work with those patients. Does anybody else have a work with a RT case manager in your programs? Yeah. I would guess in 3-4 years, I hope I see a lot of hands up.
Yeah. So with that being said, I want to comment two things. The first is usually there's a concept called team-based management. So a team can manage more patients in a way that's more effective than any single individual. You can have a superstar, most of it, And if I have to do my own downloads, do my own vitals and all that, I'll be super slow. Okay, but if I allowed, I said, people to help me, okay, and I allow everyone to work at the top of their license and use, I said, their skills and their creativity, and we all trust in each other because we all know that we'll do the job well. And then I think we can have bonds, and that is going to make things work, I said, to its best. The other thing I also have to commend is, I said, having this respiratory therapist, this case manager, is not something that is sort of like on the books or something that's needed. And to take that extra effort, that extra commitment to battle for that with administration, that just shows, I said, the commitment towards patient care that was there. So that's why I said it's just so incredible and how they punch really above their weight with it. It's so tough. But with that being said, now it's my time to flatter you here, Beth Ann. I mean, you're like one of the best communicators I know as an administrator. So I think also it's been important in keeping, I said, the team together. But tell me, what other measures have you done, I said, to keep, I said, your team engaged? Because I know that this is not a tough thing. We went through COVID, through hard times. So what do you do to make sure that everyone is pushing and rowing towards the same direction?
Maybe we should ask my team. I communicate a lot. We do huddles. We do huddles with I have what's called the Better Health Center, so I have multiple disciplinaries in there. We have cardiac, pulmonary rehab, diabetes, audiology, sleep, PFT, and dietitian services, all in our clinic, which is also a beautiful thing because how many of those things did I just say that our sleep patients need to have connections with? So it's just, I communicate a lot. We have huddles with our providers, with Dr. V, once a week. Sometimes it's just a 15-minute check-in virtually through Teams. Other times we're a half an hour. It's a way for all of us with our providers to have open dialogue, talk about what's working, what's not working. I try my best to not, one thing I've learned through leadership in 15 years is it's not my job to solve the problem, it's our job. So I could come up with a lot of ideas, but if it doesn't make sense to my team, it's not gonna go anywhere. So, just this week I met with my support team and we went over some survey results and I'm asking, them, what does this mean to you? What does it look like to you? How do you think we can get better with this? They're the ones who know better than I do. I'm here to lead and to facilitate and make the connections. They're the ones who work with the patients every day. So I just feel like we have to, in leadership, listen and ask questions. And that's what I try to do. Maybe sometimes too many questions, ladies, I don't know. Shadi?
Okay, here, Shadi says, Beth Ann is a leader, not a boss. Wow, okay. Thank you, Shadi.
Thank you.
And I must say, I'd like to add, I said, to those weekly huddles, I said, from my perspective, the reason we implemented that was, as I mentioned, to celebrate our wins. If there's any issues, to try to bring them and identify them while they're still small. But also, I said, to keep that sense of team, so we can all see each other. So although it might be virtual, maybe several miles away, we at least can once a week, we know what our faces look like. And even here, when we see each other, it seems like we've worked together forever. So that's a great thing, and keeps everyone connected. Now, tell me here, the other thing that has been quite an innovation is the role of telehealth as the success of your program. And I think you've even said something about like no-shows, but why don't you comment more about that?
Telehealth has been something that, has been around. The word has been around healthcare for a long time, right? But it never was reimbursable, so nobody ever wanted to take the venture. And then COVID happened, and people were shutting down, and I had to shut my clinics down. And it was something that we could utilize in sleep, and we had full support of Dr. Villarreal. He said, actually, sleep medicine is a perfect place for telehealth. You don't have to physically have that patient in your office to take care of them and give them good care. So that's where telehealth started for us. And I would say 100% we are the leader of telehealth at Sauk Prairie Healthcare, because we didn't stop telehealth when COVID started, when we were able to start opening up. We maintained telehealth. So even with the expansion of our program, we are now open for in-person Monday through Thursday, every other Friday, but we have 2 full days of telehealth. every single week. Both of our providers are set up, so it's a beautiful thing where a patient, now if they even have a sniffle, right, we're like, don't come in, don't come in. Hey, we can send you a link, jump on, and either Carrie or Lori will be on there, that's our providers, and they don't have to miss their appointment, or their car doesn't work, or that darn farmer who he has one more load of manure to spread and he is not going to be missing that to come to a sleep appointment, we will get him in for a telehealth. It is as simple as sending a quick link and boom, they're on. And so we have some patients that love telehealth, but it's really important that we keep that in person. And that's what we learned with adding our second provider on, is I didn't add telehealth, we actually added more in person. I don't know if that's a rural thing or not, but there are still a number of patients that want that face-to-face encounter with their provider. So we offer both. So I guess it's kind of a hybrid where at any moment, any appointment can change to a telehealth really quick. You do have to be creative. My medical assistants have to be creative at getting them downloads. So sometimes there's a bit more work on your support staff for telehealth if you have a machine that doesn't upload, collaborating with that patient to get their results. Again, I keep talking about our support staff, but it's them that keep our providers' clinic running smoothly. That's one thing with telehealth is a lot of workflow and reviewing of efficiencies and listening to your staff of what makes sense to them to keep that clinic moving. Because telehealth, you might have to see the person, but in sleep, there's benefit from seeing some of those masks that they put on their face, right? Yeah, duct tape, whatever else you guys have seen. I'm sure it's crazy stories. So how do we still give that touch to those patients? And some people are just not techie, and that's okay too, and we can see them in person. We even do telehealth in clinic. I don't know if you guys have ever done that, but our provider who does telehealth 2 days a week, she's doing it from her home, right? So work-life balance is huge. And so when you have your APPs, that if you have an ability to, I should say the word allow, but allow them to work from home and they have other dynamics, that work-life balance is going to keep them working for you longer. So even if we have a patient that really physically wants to come in, because we have some that do, these ladies will bring them into an office, they will do their part of it, they will hook up the computer, and they will allow that telehealth visit to still happen, but for the patient perspective, they're in Sauk Prairie Healthcare, in a room, seeing a real person. And so we've done it that way too.
Well, that is definitely is a very, very creative. And again, not everything is the bottom line, right? We have to think that people come first. So making sure that we do what makes sense for those who work on the front lines, for our techs, for our RNs, for everyone. So this way, I said, if you can keep them happy, then they're more likely to stay long term and be engaged in this program. And at the end, people who are happy, who are engaged, who come with ideas, make the program grow more. With that being said, why don't you tell me more about some other partnerships like the one you have with the Wisconsin Rural Health Cooperative and other things outside of Sauk Prairie that helped in this success?
Of course, with our partnership with Gunderson, but even with that, when we made the transition from, we were with SSM Health from 1990s until we switched over in 2016. We kept that I kept that relationship with SSM. It just worked more efficiently for us to go a little bit different direction, but I wanted to make sure that bridge stayed open, and it's showed to be extremely beneficial because our SSM medical director prior to Dr. V is still on our ASM accreditation staff. So she refers in to us. We don't have sleep that comes, so we have SSM and UW that actually have clinics on our campus that they rent, but neither one of them have sleep providers that come out. I think some of that has to do with us opening up our own program, but what that has done for our sleep lab is to allow the relationship to be strong so they refer into us. So I think that's really important, even if you change directions, is to try to keep that business relationship there, because it's about the patients, right? So some patients have been established through that clinic, but they've always been cared for at your hospital. How can you maintain that? You maintain that strong working relationship with those physicians and their administrators. And so that way they feel confident and they know the level of care that they will continue to feed your sleep lab, bring patients to your sleep lab. Did you have any other specific?
Yeah, so
oh,
I
the
mean,
co-op.
Yeah, the Wisconsin Co-op.
That's huge. Are there any other rural healthcare employees here? Yes? Where are you from? Elkhorn. Yes. Yes. I just saw it on one of the softball tournament schedules I had. So yes, I know. Okay, got you. Anywhere else? Yeah. Oh, Black River Falls. Yes, you guys are definitely part of our co-op. I worked with your previous director for years. Oh, good. Jackie. I'm like, it's not Kathy. Jackie. She was wonderful. She was a great mentor to me. I'll tell you that. She'd been doing the business a long time. And that is what our co-op, a Rural Wisconsin Health Co-op, it is. I don't know the number of how many rural hospitals are part of this, but it's an organization that supports all rural health care. It's a membership thing. So I have every quarter a round table that I go to, and the directors of respiratory and sleep go to this round table. We have our agenda items, and sleep is always a hot topic. Always a hot topic. And it's, again, networking, talking with other rural hospitals about what's really working well for you, what's not working well for you, so I don't maybe try that. What equipment are you using? What are you doing different that maybe we could do at our facility? It's learning from each other, and so the co-op has been huge, and I know Dr. Villarreal is also a medical director for other co-op hospitals. I kind of stopped talking about him at those meetings because they all want him too. But I don't want to share. There's only so much of him to go around. No, in all honesty though, that's what the rural co-op is for me, is to have that collaboration with peers, other sleep techs or sleep RT directors, and we talk about our programs. I had a hand up over there, I didn't miss you. Yes, Monroe is also in our co-op. Yes, you're one of the bigger ones. Yes.
So to understand, if to summarize, and would be it's important as a smaller rural hospital not to close any doors, but actually to create more bridges. So just because you couldn't collaborate in a certain program with a larger system or another sister hospital doesn't mean that the doors are closed forever, but instead maintain those relationships and try to create more bridges. And if you're thinking about investing in something like diversifying your investments, so having relationships with various places like UW, SSM, Gunderson, perhaps Marshfield or others, so that way Freighter create that healthy relationship and that collaboration that at the end it's all for the benefit of the patients. Okay, excellent. And from my point of view, the Wisconsin Rural Health Cooperative is also very helpful in the credentialing of physicians and NPs and PAs. Smaller towns have a very hard time recruiting people. I've shown you that slide. But I said, if you want to have either some outreach or telemedicine and to need some help, I said, a lot of that credentialing is sourced through the co-op. Now they can help with that. So people who might not necessarily want to move full-time to your small town may be able to work there, and the co-op helps with that. So important thing, so how did you obtain buy-in from administration? Because I said, you can say all these things, but administration to pay for something without, how did you show that proof of concept so that administration will say, yes, Bethan, we'll pay for that new hire into this program?
So I got really good at writing up performas. So performas are your projections of what kind of revenue you're going to bring in, right? They want to see their return on investment. Bethan, what are you going to do for us? Which is very fair, right? That's how we're going to keep our doors open. Data drives change, and it's hard to argue with numbers. So we were able to give a strong projection of what bringing a sleep clinic would mean to Stock Prairie Healthcare. And it even showed that we had given a 5-year projection that we'd have to grow. And it was, I think it would have happened sooner if it wouldn't have been for COVID. But literally in 2023 was our 5-year mark, and we had to double our staff. So we were able to justify our pro forma. So when I went in to get additional staff, it was a lot easier for a buy-in because, and we actually just went through this with the team this week, the clinic the clinics will bring you some revenue, correct? But our goal is to get that patient to our lab, right? That's no secret. The lab is where it's at. We need to keep the lab, whether it's in lab or home tests, going for our patients. And so that's why we need to keep those clinics open for new patients. I was quite happy when they approved my RT sleep coordinator position, because that was one that was like, I asked for some stuff that I'm like, oh, this is a shoe-in, but that was like the star in the sky that I didn't really know that I was going to get oh, okay. But I did. But I did it because I kept the patients in the center of my proposal. With every single thing they asked me, I made sure my answer was always that patient came first. And if you want to take care of your patients, I need to have the staff that can support those patients. And with that, in allowing them to take care of these patients, it allowed the clinic to see more new patients. So that Performa, you need data. Just to go in to say, hey, I need this, you need to go in with your numbers, you need to go in prepared, and always keeping that patient at the center while showing them your return on investment. There's a lot of power in sleep. If you need any help, you can always reach out to me. And no, don't accept no. I don't accept no. I say, what more do you need? I will tell you, you have to go back a couple times. It depends on your administration, but that's their job. If they said yes to everybody's ideas of opening things, you probably won't be open very long. But if you go in there with your proposal and you'll feel great about it, you're going to get a lot of questions. And don't get defensive. Ask, what more can I give you so you can better understand what I'm trying to explain, the need? And write it down and say, okay, I'll make an appointment with you in 2 weeks. Oh, she's coming back. Yeah, I'm coming back. I'll keep coming back until I have done my job to show you what I need. So data, when they ask you questions, ask them back, what do you need from me? What would help you see that this is what our community needs? It really helps if they also have had experience in sleep, maybe as a patient, but yes, use those community links that you have. Like that gentleman who talked to us, that was perfect. Like, I hope he talks about his sleep apnea to as many people as he can, because that would impact to make it as personal, right? Any of you guys listen to the Bobby Bones show on the radio? Hey, he's been talking up sleep, and he loves his CPAP. So I'm just kind of waiting for that to come around. I want to get that podcast. But at first, listening to him describe what the sleep tech did to him was hilarious. And then he's like, I don't know about this. I went to this building, and there was nobody there. It was dark. They told me to call, and this lady showed up, and he was all skeptical. But then he got his machine, and he is broadcasting across country music how much CPAP has made a difference in his life. More people need to speak up about like that. So use those personal touches.
Awesome. So that's summarizing, showing the data. So again, if you want to prove the need to administration, you need to put yourself in their position. If you had to pay for something out of your pocket, would you just put money there if you're just going to lose it, not get anything in return? Probably not. So it has to make sense. It has to be something that will be self-sustaining. And again, not everything is the bottom line, but it has to make some sense that it won't be like a huge money loser. The second thing is always having, I said, patient care as your North Star, right? Always, it's all about patient care. And again, those sleep studies, we said it's only when clinically appropriate. That's the one thing I have to say. So it's never, we don't want to do a study on everyone, just when it's appropriate. So, and then the other thing too is tying that data with a story, right? Because the story gives it like that personal connection, okay? You can tell all the numbers, that might jibe with some, but if you use data plus a story, some storytelling, it becomes very powerful. And the final thing, if you heard and paid attention, don't give up, be insistent. If they say no, so I'll just ask why, or what else you need. Let them give you their reasons so that you can understand and go back to the drawing board and research. So just be insistent, don't give up. Excellent, wow, that was fantastic. So with this, I'd like to hear some questions here from the audience. Regarding
your sleep coordinator, you mentioned that they are an RT. Is that a position that's fillable by an RT, or
so let me So we will repeat the questions so that the audience online can hear it too. So I was saying regarding the patient care coordinator, was a respiratory therapist. It's a billable. Can they bill for what they do? And could a sleep technologist also bill for those procedures? Is that correct?
It is my understanding that the answer would be yes, in that my RT is not billing. He's not using his own NPI. He is billing under the provider. So that's that incident 2 that I really encourage you guys to look into. As long as that physician is working on that same day, and that the key is the patient has to be established. But if we're the providers and I'm the one who ordered it, but he's the one working, that's fine, he's in my program. So just as long as it's an established patient and they write a consult to your case manager, the case manager will go and have their templating and do all the documentation. We have then sent to cosign by the APP, and then the APP bills that out.
So the other 2 things are it can't be the same day as the face-to-face. So if they had an appointment with your clinician, they can't go, say the RT, that would be considered double billing. So that's a big no. And then you do the billing by half an hour to an hour, so 30 or 60 minutes. Mm-hmm. Sure. Any other hands? Yes?
Just wondering if you've explored or if you have opened any like Sleep Navigator or inpatient screening programs?
Asking if they, can you repeat the question perhaps? If they opened any Sleep Navigator inpatient sleep screening program.
You're reading my mind. Not yet. Baby steps. No, definitely there is a role for that. You see navigators for all kinds of disease processes. I think sleep would be key. I think if we could coordinate that with our pre-op nurses or our pre-op nurse navigators, I think that would be a good opportunity for us and for many clinics. So potentially in the future.
So to the point of networking, let's connect. I've got all the answers that you need for that.
And to that too, let me tell you that if you Google here, it's at Sauk Prairie, like sleep apnea anesthesia, you'll see that they were in the verge of getting started with this. And even they had something published for 2018, but then the pandemic happened and they put a kibosh to that. But
I read something. That's where I was like, I swear that I read something.
Yeah, we did.
In my presentation.
Yeah, we did. So we have, all the assessments built. Every patient that comes through does what we call our OSA protocol, and then that gets, for inpatients, goes to the RT department. Currently, right now, the nurses take care of it in the surgery center to do their education. Ideally, I would like to have that sleep educator there to take it to that next level and actually get them to commit to being seen in a clinic before they get there for their same-day surgery. If anything, surgery motivates patients, so if we can get them beforehand and get them on that journey, that would be key. So, yeah.
And also for anesthesia, another thing too, and I had a conversation with someone here too. I can tell you here in Milwaukee is that a few years ago there was a healthcare system, I wanted to mention it here, but they were forced to develop a sleep apnea screening program so that the malpractice premiums for their anesthesiologists don't go up. And so they had to do one, out of scratch, and they were forced to do that. So depending on the group and how it is, another selling point is most people who do anesthesia, they don't want any unplanned complications for a planned surgery. That's the last thing they want. There is also the Society of Anesthesia and Sleep Apnea. You can look it up. They have their website and their own guidelines. And they tend to use the Stop-Bang questionnaire. And for those who have a score of 5 or higher, they tend to push towards having home testing. And for those with a score of 3 or 4, they say do anesthesia with precautions. But yeah, you can look into that. And obviously, if it's emergent, well, that they have to have the surgery anyway, so that won't wait. But yeah, you can use that as a resource too. Again, I'll tell you, whenever you talk to a person who belongs to another specialty, try to look into their guidelines. So, because they believe their own tribe. Say, look, your tribe says you should check for sleep apnea. Then if it's cardiology, look at the cardiology guidelines. If it's endocrine, take a look at those endocrine guidelines. If it's anesthesia, look at their guidelines. Yeah. Great. Any other questions? Yes?
There's a question from Zoom from one of our attendees that is asking, do you feel it's important for the manager of a sleep center to experience in sleep, or can it just be an RN or someone with no experience in sleep?
Okay, so question from Zoom. So the question was, do they feel that the manager must have experience in sleep, or could it be a person without any previous experience in the sleep field, like a nurse? What do you think, Bethan?
How to answer this? No. It depends on the leader. I am not a sleep tech. You guys looking at these, what I say, squiggly lines, amazes me what you guys see. If you have the right leader who listens and wants to learn, they're the right person. It doesn't matter what's behind their name. You heard me say other disciplines I oversee, dietitian services, cardiac rehab. I'm not an exercise physiologist. I'm not a dietitian. But you know what? I lead strong teams because they're my resource. I do what they ask, but I bring it to the strategic level. So if you have the right leader who will listen, I don't know that it matters what credential you have behind your name. If you're willing to learn about that, you have to care about it. I could be an RT or a sleep tech. You all care about what you do. So let's say if I'm an RT and I'm not as passionate about sleep, it's probably not my business to lead the sleep department. But I am passionate about it, so I think I am a good person to lead it, and despite what's behind my name. Do you guys agree? What do you guys, does somebody report to somebody that's not an RT or a sleep?
So Bethan, before someone answers here,
Yeah.
let me tell you, I agree with everything you said. That I'd like to add one more thing, and this is a bias that I have, but I feel that regardless of their profession, so they don't have to be a sleep specialist in my opinion, but I feel that it's very important that manager has a clinical background. If you have someone with a pure, I don't know, business or background that has nothing to do with healthcare, I find that the level of empathy towards what has to happen towards patient care, they try to find sometimes shortcuts. They're not necessarily the best in the best interest of patient care. That's been my experience. Again, I can't say I have any clinical trials to prove it, okay? But that's just what I've found. So let's open it here to comments from the public. They say we have Epic. No, Sauk Prairie has something else. Yes.
We have a navigator. Our manager currently now helps us get, it's called Compass Rose. I work for children, so.
Do you mind taking a break and see if someone can give you a microphone, please? No?
I'm going on location. Second.
This is so that the people online can hear it.
I'm Sue. I work for Children's. Half my team's there, half my team's here. But we just started a Compass Rose. It's part of Epic. It's a navigator. We follow about 300 kids. I'm actually kind of like a sleep coordinator. I'm also an RT, and Tamara works. She's the other half of our team. So we do follow about 300 and some kids on varying degrees. So, and we do have a clinic, and I work with Megan Grekowitz. She's the nurse practitioner provider, so we do work under her, so we're able to, and Deb Anderson, she's our other nurse coordinator. So, yeah, so if you're ever interested, Rebecca's our supervisor, so you can always pick her brain if you'd like.
Well,
Thank you.
how many people are here from Children's? Raise your hands. Wow, thank you. Hey. So any other questions here from the group or Zoom?
Got you. Can I say what Shadi had something quietly to share with me? Shadi wanted me to, and this might be unique to Sauk Prairie Healthcare, we have two different positions. We have our sleep lab coordinator, and then I have my RT case manager. So we've talked a lot about the case manager and more of that navigation role. My I walk over here like this is my other side. The sleep lab coordinator, that individual is sometimes referred to as your daytime tech on steroids. She does our scheduling. She does all the home sleep apnea testing. She is the one that makes sure that our sleep techs have exactly what they need at nighttime. So she scrubs the charts. She helps me with the ASM QI projects. She is the one who keeps our lab operational, talks with patients post-study, and then she works very closely now with our RT case manager. So we see a handoff of care, right? So the coordinator works with them from scheduling their test to completing their tests, calling them with the results, sending the info to the DME with the MAs, and then there's that handoff of care over to our RT case manager. So we do have 2 separate roles for that. We tried to do it with one. It's way too much work. You need to have 2. At least we do.
Okay, team, thank you very much. And Beth Ann will be available for any additional questions here. So let's please give her another round of applause, please.